I will try to give a not very conventional lecture today, because I could talk about Temodar, radiation, lomustine. I don't think it will be very informative. So I'm going to go in a direction where I will try to push the envelope and ask more questions about the future than give you answers. But let's see where we go. And again, I'll be very happy to answer all the questions. And again, thank you for having me today. And this is on the left and in the middle, the beautiful landscape of New Mexico here. My disclosure, as you said, I'm now Vice President at Daiichi Sankyo. I overview all the strategy for drug development. So this is the slide I'm using every year when I give a talk. And this is not very good news, because this slide has not evolved as standard of care for the treatment of glial tumors over time, as you know better than I do. And if I ask you to see where Temodar is listed in the standard of care therapeutic options, we'll see Temodar everywhere. And if I ask you to list CCNU and PCV, unfortunately, PCV is still everywhere, as we can see. So it's a terrible situation. I am so sad every year to say the same thing about our standard of cares in the medical neuro-oncology field, because nothing has evolved. You neurosurgeons, you have made much more progress than we did. Maybe radiation did some progress, but this is a terrible situation. When I met Roger Stupp for the first time, it was 15 years ago, he told me, hey, I hope one day there will be no more Stupp regimen, and I hope it will be before I die. I don't know how old is Roger Stupp. He might be 60, early 60s. I hope he has a very long lifespan, because I'm not so sure that we won't talk if you re-invite me in 10 years about the Stupp regimen. And as you know, despite all our efforts, all the things we tried, we are still talking in weeks of survival for glioblastoma, and nothing has really changed in terms of median of survival. So that's my first quiz. Do you know this guy? If you know, you win a direct ticket to Santa Fe and you stay 1 week in the hotel here. So this is Jean-Martin Charcot. In France, we consider him as the father of neurology. And I was honored to, my office in Paris at Pierre and Marie Curie was his office. So I was quite, each time I was in my office, I hopefully inspired by Charcot. But there is a second quiz coming, so stay tuned. So the first thing we try to do is to, when you don't have so much good treatments, you try to reclassify what you are doing. And as you know, there are those WHO classification over time coming. I'm still trying to understand how it could impact our patients. So this is 2007, and this is a recent one. Is it important in terms of research and care to have this new classification? You could say yes, or you could say no. Now we have a molecular staging that's quite new, but we're going to discuss how the column on the right is important, how those mutations could impact the outcome of our patients. We probably better classify those subtype of gliomas, but is the gene molecular profiles going to impact the outcome, because we'll have different way of treating those patients? I am not sure, and I hope we'll get some answer at the end of my talk. The neuro-oncologist had a dream, is to have a classification like in breast cancer, where we have 3 or different subtypes with different outcomes and different therapeutic options. And that was the first try with 6 main genes on the left that could predict the outcome, and with also the dream to have a special therapeutic intervention. I don't think we are here like we are in breast cancer, where things are totally changed based on the luminal A, luminal B, and other subtypes, but there is maybe something cooking here. Of course, IDH1 mutation is a prognostic factor. MGMT is a prognostic factor for survival, independently of treatment, and it's maybe correlated with the efficacy of chemoradiation when you're MGMT methylated. We know that, but we are stuck with this observation for decades now. So this is, again, the terrible status. These are the FDA drug approved in gliomas, and we haven't made progress. I won't say again more than that. So what is the story over those, and what are the lessons we have learned from surgery, radiation, chemo combination? Something quite new happened finally in the 90s with the targeted therapies in every type of cancer and, of course, in brain tumors. So where are we with this story? Targeted therapies have not really in any cancer changed the outcome. We don't have real long-term survivors, for instance, in kidney cancer with TKIs. We have changed the initial response, but overall, the patients with advanced disease haven't changed we haven't changed the real outcome, which might be, as we'll talk later, a little bit different with immunotherapy. So the big story, of course, is to have seen all those mutations published from the scientists. And we see a different landscape from secondary GBM to primary GBMs with different types of mutations. But we can obviously say one thing. Unfortunately, the molecular alterations we see here are mostly loss of genetic material. P53 is an example. And we are talking mostly about suppressive oncogenes. We are not talking about oncogenes that are drivers for the cancer proliferation for the GBM, which would be easy targets for targeted therapy. So obviously, the first targeted therapy has been bevacizumab. And the first thing to do was to combine Avastin with Temodar radiation. And there are multiple large studies. And as you know, we haven't seen a clear impact on those survival curves. We probably have a gain of sometimes based on the study, the patient selection by a month, but overall, we haven't seen any advantage. We all use Avastin as a super steroid, but again, if we look at the survival curve, we don't see a real impact. And there are multiple ways to address the Avastin as a frontline treatment, no real efficacy. As a first relapse, as you can see, it was compared to lomustine. There was no real benefit. Again, for a few weeks, the patients are probably doing better, but the survival curve won't change over time. So in terms of next generation of targeted therapies after Avastin, we were able to have multiple targeted therapies that interact with tyrosine kinase. And these are in each box drugs. And the tree is a kinome. We have hundreds of kinases in our normal cells or cancer cells. And you see the dot, the red spots are how those kinases, tyrosine kinase inhibitors interact with the tree with one tyrosine kinase or with multiple tyrosine kinases. So we have drugs that are very clean drugs, have one interaction with one kinase, and drugs that will interact with multiple kinases in the kinome of the cancer cells, and in particular the gliomas. So we had a dream. You have one target identified by a molecular screening, and you have one drug that can interact with this protein, this oncogene, and it will be the cure for GBM. We really thought it would have been a good option, and obviously it's not. So my experience, I can tell you, is what everybody experienced in the lab and in the clinic. So we had preclinical data published in Science showing that in glioma cells and in hepatocellular cells, when you block the mTOR pathway, you upregulate other pathways. Here is PI3 kinase. And in the context of PTEN deletion, we thought that the combination of two drugs, mTOR inhibitor, a PI3 kinase inhibitor, in combination will be the answer, because you block a pathway and you don't upregulate another pathway, which is a way for the cell to survive. So we published this in Science, and to be honest, we cured the mice. It was a real home run. So we immediately, I was at that time at University of Cincinnati, decided to do the combination of those two drugs in brain tumors and in hepatocellular carcinoma. And here is the answer: no data. No data because we had to stop the study after 3 patients. To be able to block two pathways like mTOR and PI3 kinase, you block the entire metabolism of the patients. So we couldn't dose escalate because the patient was the limitation. The mice didn't tell us that they were extremely tired. They were not able to really walk and run, but the patient told us right away. So good hypothesis, impossible to translate in the human setting because you maybe block both pathways, very important for the proliferation of cancer cells, but you also block the own metabolism of the patient. So where are we with those stories, with those inhibitors to inhibit a specific driver mutation? This is the ongoing studies in 2022 about targeted therapies. You see, it's not a very long list, but there are 2 main candidates, BRAF and FGFR, which are probably with IDH1, the 2 or 3 main targets that we are still trying to investigate with one pathway, one drug. BRAF, FGFR are very rare events that we report when we sequence the tumor of the patients with GBM, 10–15%. It has been a home run in melanoma. In melanoma, when you have a BRAF V600E mutation, you give a BRAF and MEK inhibitor at the same time, you have a 60% response, and you probably have a very, very long outcome. So things are trying to be investigated the same way in GBM, and we don't have a clean cut, but for sure, it's related to a very small population of patients, but probably a good option, like also FGFR inhibition. FGFR inhibitors are extremely toxic, very difficult to manage. So we'll see where we go if we have really a long-term impact with those strategies. But again, the message here, you block one pathway, and this complicated picture tells us that you upregulate other pathway where the cancer cell is able to survive and to overcome the blockade of one specific way to treat cancer. So again, we'll see in the future if using those classification will help us to navigate in very targeted therapies and to right away identify the 5–10% of patients that could be good candidate for one day maybe standard of care with a BRAF, FGFR, or IDH1 inhibitor. In order to better select the patient for targeted therapy for specific mutations, we need, of course, to do a full deep next generation sequencing analysis. And it's not easy, as you know better than I do, in brain tumors. We most of the time have the initial biopsy, but it's difficult most of the time to rebiopsy patients when they relapse. When I was at University of Cincinnati with Mustafa Bahasi, we were the first to identify that there was circulating DNA from the tumor in the blood of GBM patients. And we published this, and we were very surprised that 60 to 70% of the patients we could detect by RT-PCR circulating DNA from the tumor. And it was interesting to see that the pre-op, post-op, after a gross total resection was also a way to see if there was a significant or less residual disease in the circulating, from the circulating DNA with those patients. Nowadays, it's a technology we use in the US as routine. We use Guardian 360 and other platform. And from GBM patients, we can track from the blood the mutational landscape of one specific patient. And interestingly, we can use it over time and see how the mutational load evolve over time. However, there are bad news. Bad news because the mutational load, the number of mutations, as we said initially, is very low in glioma cells. You should really read this paper in Nature from our colleague. We have been working with him, with Omar, Ludmila Alexandrov. He will get the Nobel Prize one of those days. He was one of the first to describe the mutational load in different tumor types. And you see that glioblastoma on the top of my screen is having a low mutational load when you compare with other tumors like melanomas. And that will impact, one, the number of pathways we can target, and two, it will have, in a minute, as we are going to discuss, an impact on immunotherapy. So this is my second quiz. Who is this guy? It's Joseph Babinski, and I shared my office with Babinski because, as you know, Babinski was the fellow in Charcot's department in Pitié-Salpêtrière, and he took over the Department of Neurology a few years later. So again, I am inspired by Charcot and Babinski. So the next step is, do you see my screen well, or you see also you guys and me on the right side?
We see the screen. We see the screen very well.
Full screen. Okay.
You have circled the immunotherapy.
Yeah. So immuno, where are we? Of course, it's a good way to be at the front page of the Time magazine and say, okay, we are going to cure GBM with immunotherapy, because it's very fancy and everybody is talking about it. Unfortunately, over the past 10 years, we had a long list of immunotrials. This is only one page of 10 pages. That was the clinicaltrials.gov report from 5 years ago. And this is what we have now as real ongoing immune trials. So that tells us that it has not been a real home run when we see that, and when we see the standard of care where nothing about immuno is listed in 2022. So we have in GBM 3 ways to address immunotherapy. One way is to tackle the loss of antigenicity. The second way is to attack the loss of immunogenicity. You have no real T cells to answer the questions. Or the third way, you have antigens that are the target for the immune system. You have extremely efficient immune cells, but you have a microenvironment, a milieu, which is extremely immunosuppressive. And despite the very expanded T cell activity, you don't have any efficacy from your immune system. So these are the 3 ways we have seen in GBM. And I give you a few examples of failure and maybe potential successes. So obviously, as we did with every tumor type, these 2 pathways have been the big target in GBM. One is the connection between T cells and dendritic cells. The other one is a direct connection between T cells and cancer cells. And that could be addressed with the CTLA-4 pathway and the PD-1, PD-L1 pathway. And we have drugs that have been extremely successful with those 2 pathways in melanomas. And you see the outcome in melanomas has totally changed. We have long-term survivors. And I have now patients stage 4, 10 years after, with no relapse, that are probably cured in stage 4 with those CTLA-4 and PD-L1 inhibitors. But in other tumors, we had some very bad signal. In head and neck cancer, the impact of PD-1 inhibition was very mild, 2 months of gain of survival. And unfortunately, despite perfect design of studies, nivolumab, ipilimumab, PD-1 CTLA-4 inhibitors have been tested in combination with chemoradiation, frontline, or in recurrent GBM. And as you know, the impact has been from almost 0 to 0. So what are the explanations for that? The target PD-L1, how is it expressed in GBM? We know that the level of expression of PD-L1 is very complicated to evaluate in glioma cells because there is heterogeneity in the tumor. And there is probably variations over time. We have here on the upper left a patient with initial positive PD-L1 tumor, and patient at relapse lose expression of PD-L1 expression from 60% to 10% when they relapse, when we have match sample, which is quite rare. So the problem is here, PD-L1 is one synapse in the T cell, dendritic cell, cancer cell discussion. And all those other pathways are all the pathways that will activate or inhibit the T cell activation in order to attack the cancer cells. So I don't know if it's good news, but it's probably bad news because it's going to be very difficult to block the signal or to activate the signal in order to activate T cells and to have a real immune response. But the good news is that we have extremely potent drugs now that are able to intervene on all of these pathways. This is a slide from 4 years ago where we were talking about B7-1, B7-2 on the upper left, which is the PD-L1, PD-L2 pathway. We are now working on B7-3, which is an incredible potent pathway with the CD47. And we have incredible drugs that we are testing now in phase 1 that have extreme activity even when the patients are PD-1 negative. The second way was to reverse immunosuppression. I told you there is an immune milieu which is very immunosuppressive in GBM. Maybe in any cancer type, it's probably where the immunosuppressive environment, the microenvironment is the highest in terms of immunosuppression. Why? I give you an example. This is the placenta of mice, and one of my friend and colleague, David Mann, saw a protein overexpressed in the placenta. And guess what? If this protein is not present in the placenta, we won't be here to talk because there would be no maternal-fetal tolerance. The placenta is a very immunosuppressive milieu. So that's why the embryo and the future baby can grow in the belly of the mom. And guess what? What David Mann showed, the glioma cells are able to express IDO, which is the name of this protein. So the glioblastoma tumor is doing exactly what we have seen in the placenta. There is an overexpression of this protein, IDO, which totally blocks T cell response, NK cell response. So I was at that time working in the lab with David Mann, and I said, David, we have a drug that blocks IDO, so why don't we go right away in the clinic and in gliomas? In particular, because we were able, when we combine an IDO inhibitor with radiation and Temodar, we were able to have a real synergy. So we decided to go in the clinic with a very strong rationale. And we did this study with this drug called 1MT, which blocks IDO. So the deal was to block the blocker and to release the brake and have an immune response. The data are not published. It will be published soon, but we have seen zero activity. When in melanoma, we have a real home run. So that tells us that the microenvironment in GBM is much more complicated than other tumor cells. And despite the very strong rationale, we had no real signal. When again, with the same strategy in melanoma, we have an outstanding outcome. We published in melanoma the data very recently. So why? There is another story, the neoantigen load. Cells are able to produce cancer cells, neoantigens with a defect in the RNA repair, and that brings new antigen at the surface of the cancer cells, which is an advantage for the cancer to proliferate, but also an advantage for the immune system to recognize those neoantigens that are not expressed on the normal cells. So that's probably why melanoma is a home run with those immune therapy, because the neoantigen load is very high. It's extremely low in GBM, and that's the other bad news. Another story is the TMB, the mutational load, the number of mutations acquired over time in GBM. And to make a long story short, I would like to go here. If you go on C and in the bottom left, you see that you have very few patients with glioma having a high mutational load and a high PD-L1 expression. So unfortunately, most of the gliomas are TMB low, low mutational load, and PD-L1 low. That probably explains why there is a very low T-cell activation and why those interventions blocking those pathways don't work well in this setting. When in melanomas, the TMB is very high and the PD-L1 expression in most of our patients' tumors is very high. So that's the opposite model. Last example I would like to give is to deliver the tumor antigens that have been lost over time. And I've been exposed with this story EGFR-V3. So EGFR-V3, as you know, is a abnormal binding site for EGFR in the cells, and it has been so it's a deletion and a mutation in the binding site for EGFR. And we knew that, and we still know, that 30% of GBM carries this EGFR mutation. So you heard this big story with the peptide mimicking the mutation for EGFR-V3. And we conducted studies with patient with relapse GBM with an EGFR mutation, using this peptide being injected subcutaneously. And in the phase 1, phase 2 studies, we have seen a very strong signal for patients who had extreme relapse. We had median progression-free survival in the phase 1-2 studies of 12 months, which was quite unusual. So the deal was to, after complete resection of recurrence, to do this big study, vaccine plus Temodar versus Temodar. And the result is here. There is absolutely no impact. So that's another lesson I heard in gliomas. We have most of the time, with smart strategy, a very good signal in the early phase of drug development. And I don't know why. Probably we select better the population. And when you do the big phase 3 study, if you look at the last 100 phase 3 study in GBM, they are all negative. So we have to be humble when we claim in a beautiful paper in phase 1-2 that we have the next treatment for GBM. We have to know that the story might be different, and the patient selection, the I don't know what is going to affect the final result. So there are multiple stories now with peptides loaded in dendritic cells. We stay tuned. There is no real good outcome yet, but you can upgrade the dendritic cells with after loading ex vivo and reinjection of the cells. And again, there are multiple experiments here. There are also still some gene therapy and viral therapy to use adenoviruses or herpes viruses, oncolytic viruses that are currently used. There are 4, 5, 10 studies ongoing, especially after gross total resection. That's probably where those viruses are going to be efficient. So it's really a neurosurgical experiment, as most of you, I guess, have been exposed to. One more thing about trying to reprogram the innate immunity. We have all a very strong innate immunity, but in GBM, those macrophages or myeloid cells that we carry that are able, with no education, to recognize cancer cells, there is still a problem and it doesn't work. So I was telling you on those pathways, dendritic cells to cancer cells to T cells, there is a big target coming. It's to re-educate the macrophages. So the macrophage, a myeloid cell, is a big target for the future treatment of cancer through a different kind of immunotherapy. And if you look at the CD40 SIRP alpha pathway, it's a pathway that communicates between macrophages and cancer cells directly. And the pathway inhibits the macrophage for eating. It's a eat me pathway, the cancer cells. So there is experiments. Here they use alpacas. I don't know if you have alpacas in Pakistan. We have alpacas here in New Mexico.
No, we don't.
And they had some ways to get through a phage display technology, SIRP alpha immunofluorescent probes. And you can do two things. With this pathway, you can extremely well diagnose and image GBM but it will be using SIRP alpha inhibitors, the next generation of treatments that we are going to test in the clinic in GBM and other tumor types. So stay tuned. The macrophage is a target for the next 10 years. We are going to be very busy with the macrophage in the future. My last story I would like to share with you is to say, okay, having a targeted therapy is complex. Working with the immune system is very complicated. Why don't we go with a very basic pharmacologic intervention with trying, for instance, to just specifically disrupt the membrane of the glioma cells. And that's what we did, and I presented at ASCO in the oral session this strategy. We were able, when I was at University of Cincinnati, to identify this drug, BXQ350. And this drug is a protein encapsulated with a liposome. And it interacts with the external membrane of the glioma cells, extremely specifically. It doesn't interact with normal cells. And it disrupts the membrane and it can induce apoptosis. We had extreme efficacy to use this molecule to image glioma cells, but also we had incredible activity in vivo and in vitro with no cytotoxic effect on astrocytes. And these are the cells on 1 and 2, mice 1 and 2 treated with the drug. Over time, you see that the mice number 1 and 2 have no brain tumors, when the control mice do die from glioma. And this is a survival curve of our animals treated with GBM, orthotopic model with this drug. So we conducted a phase 1 study, and this is a presentation about the glioma patients ongoing. And we have 2 patients, this is one of them, with an extreme large bulky relapse, having a clear response on treatment. So this drug hopefully is going to be used in phase 3. I don't know where we are going to go with that. Again, let's stay very humble. We have a strong signal with few patients. Are we going to replicate that in phase 3? I don't know. It's not immuno, it's not targeted therapy. It's a very simple disruptive agent through the external membrane of the cancer cells. My last slide is this. When we have relapse, we should really consider research, trials, investigation on those patients, because reintroducing Temodar, using Avastin or Lomustine will have a very limited impact on the patient and on the overall trajectory for the treatment and the history of GBM. So we have really to be connected every day with research and to try to be as innovative. But I hate innovation for innovation. This innovation has to bring something on the table as a clinical benefit, which is not always the case. I don't know. Let's go in other directions. Ketogenic diet. I have a patient in Cincinnati, 2012, bulky disease, massive relapse, surgery, second surgery, horrible molecular parameters. And she said, I don't want any of your pills, doctor. I'm going to be on a ketogenic diet. The other day, guess what? I went to Cincinnati. I was in a restaurant and she said, Dr. Rixe, you recognize me? I said, I can't believe it. So she was a long-term survivor, #1 for me, on ketogenic diet. And there is a lot of science between a more holistic care. It's not about drugs only. It's about a spiritual healing. It's about the metabolism of our patients. Most of our patients in the US are obese when they are diagnosed with GBM. It's a bad combo. And Where is our intervention? We are not here only to do surgery, radiation, and give a drug. We are also here to change the metabolism of the patients. There are a lot of studies to use those strategies with, again, changing the metabolism through drug interventions, through diet, through supplements. I'm a believer of that, and we'll see where we go. And it might be, when we talk about immunotherapy, a perfect combination. We change the gut microbiome of our patients. We enhance the potential response to immuno. I wanted to thank you for your attention. This is a beautiful state of New Mexico. And I'll be happy to take, hopefully I haven't been too long, a few questions. And thank you again for your very kind invitation.